دكتور. طيب بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. سعادة عميد كلية الطب الأستاذ الدكتور خالد فودة، سعادة وكيل الكلية الشؤون الأكاديمية الدكتور صالح الظاهري، سعادة رئيس مركز الأبحاث بكلية الطب الأستاذ الدكتور عبد الرحمن السلطان، سعادة وكيل كلية الطب للدراسات العليا الدكتور مثنى الرحيم. الصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. سعادة عميد كلية الطب الأستاذ الدكتور خالد فودة، سعادة وكيل الكلية الشؤون الأكاديمية الدكتور صالح الظاهري، سعادة رئيس مركز الأبحاث بكلية الطب الأستاذ الدكتور عبد الرحمن السلطان. نرحب فيكم في الملتقى مجلس الطلاب الثالث للأبحاث. طبعا بدأ العمل على الملتقى منذ بداية العام الأكاديمي الماضي، وخلال فترة استقبال البحوث تم استقبال ما يقارب 250 بحث من مختلف التخصصات الصحية، وبمساعدة ما يزيد عن 20 محكم من أعضاء الكلية كمحكمين ومحكمات. تم تقييم الأعمال المقدمة وترشيح الأبحاث التي يزيد عددها عن 120 بحث يتم عرضها يومين الجمعة والسبت. بداية نرحب بالأستاذ الدكتور خالد فودة عميد كلية الطب لافتتاح مجريات الملتقى. تفضل دكتور.
السلام عليكم ورحمة الله وبركاته. أتمنى الصوت واضح. بداية أحب أن نرحب جميع أبنائنا الطلاب والطالبات سواء من كلية الطب جامعة الملك سعود أو من الكليات الأخرى المشاركين في هذا الملتقى الثالث لأبحاث الطلاب بكلية الطب جامعة الملك سعود. بداية أحب أن أهنئ وأشد على يدي كل أعضاء المجلس الطلابي سواء السابق أو الحالي الذين ثابروا برغم من كل الصعوبات الموجودة واستطاعوا أن يعملوا حتى يصلوا بهذه النتيجة. ولعل هذا يكون أول درس لنا جميعا أن المثابرة تحقق نجاح بإذن الله تعالى. كما أني أود أن أقدم شكري الجزيل لسعادة الدكتور صالح الظاهري وكيل كلية للشؤون الأكاديمية لرعايته لهذا المؤتمر، وخالص الشكر والتقدير لوكالة الكلية للدراسات العليا والبحث العلمي ممثلة في سعادة الأستاذ الدكتور ماجد الماضي لدعمه لهذه الملتقى، وأيضا لسعادة الأستاذ الدكتور عبد الرحمن السلطان مدير مركز الأبحاث لدعمه لهذا الملتقى، وكافة الزملاء في مركز الأبحاث وعلى رأسهم دكتور مدخلي الذي كان له دور كبير وأساس في إنجاح هذا المؤتمر. بالطبع هذا المؤتمر سيكون علامة فارقة للطلاب، ليس فقط لتجميع هذا المجموعة الرائعة من الأبحاث، ولكن للمثابرة للإبداع في طريقة الإلقاء والاستمرار في العمل بصورة تشرف الجميع. أتمنى لكم يومين رائعين تنالوا فيها من العلم، ويكون هنالك العديد من النجاحات المستقبلية لكم تبنوها اليوم وغدا بإذن الله تعالى. السلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله. يعطيك العافية أستاذ الدكتور خالد فودة عميد كلية الطب على الكلمات المشجعة. ننتقل الآن إلى الدكتور، طبعا استأذنا أستاذ الدكتور عبد الرحمن السلطان الحضور اليوم، لكن راح يكون معنا في وقت الكلوزنج سيرموني في الغد. فننتقل الآن إلى أستاذ الدكتور خالد صالح الظاهري وكيل الكلية للشؤون الأكاديمية يلقي كلمته. تفضل دكتور.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. أولا حقيقة يثلج الصدر أن ترى الإعلان مبوب على أساس أنه المؤتمر الثالث وليس المؤتمر الأول. وجود مؤتمر ثالث بلا شك نجاح التجربة السابقة. التجربة مرت بمرحلتين سابقتين في ظروف مختلفة عن ظروفنا الحالية الآن، لكن مثل ما ذكر سعادة العميد بلا شك المثابرة وتخطي الصعاب هي أولى خطوات النجاح. نجاح المؤتمر السابق أو الأول كان بمثابرة مجموعة من الزملاء الآن هم زملاء لنا في التخصص، يعني أقدر أقول كسروا كل القواعد اللي كنا متعودين عليها، وأرادوا إثبات أن الطلاب يستطيعون أن ينجحوا بمؤتمر مستقل لأبحاثهم الطلابية، وكان الإنجاز رائع جدا. المؤتمر الذي يعني عقب ذلك المؤتمر أكد هذا النجاح. الآن مع كل الظروف القائمة وكل يعني ما واجهناه في العملية التعليمية والمؤتمرات في العالم ككل، يظل مؤتمر الأبحاث الطلابية في جامعة الملك سعود يقام وبطريقة جديدة، ويشارك فيه أكثر من 250 بحث. حقيقة هذا إنجاز أنا أعتبره هو النجاح الحقيقي في كل هذه المنظومة. البحث العلمي بشكل عام للطلاب هو عبارة عن غرس، يحتاج إلى عناية، يحتاج إلى يد ترعاه، يحتاج إلى صبر، ويحتاج إلى يعني الاختيار الصحيح للبذرة والأرض والهدف اللي يسعى الشخص الحصول عليه. قد يحصل على فاكهة، قد يحصل على وردة، قد يحصل على شجرة خضراء، وقد لا يحصل على شيء. فهذه كلها يعني تنميها، أو كل هذه المهارات وهذه يعني الأشياء اللي يحتاج أن يكتسبها الطالب تنميها مثل هذه الأبحاث. المؤتمر أيضا يضيف بعد آخر لقضية البحث العلمي، وهي القدرة على عرض الفكرة، تبسيط الفكرة، تجميع الأهداف وعرضها بطريقة مقنعة. وهذه أيضا مهارة يعني لا يستطيع الشخص أن يمتلكها فقط بالكتابة، وإنما يضطر للتقديم، ويضطر للدخول في نقاشات، ويضطر للعرض على محكمين إن صح التعبير، من أجل أن ينمي هذه المهارة عنده. فأنا أقول يعني المؤتمر هذا هو نجاح للكلية، نجاح للطلاب في جامعة الملك سعود، نجاح لطلاب كلية الطب في المملكة ككل، وليس فقط يعني في جامعة الملك سعود. الجهد اللي قام فيه الزملاء حقيقة لا ينكر، وأحب أني يعني أؤكد على مجموعة حقيقة من الزملاء اللي لهم اليد الكبرى حقيقة في إنجاح مثل هذا المؤتمر. لعل الدكتور عبد السلام مدخلي والجهد اللي قام فيه والصبر والتواصل مع الطلاب منذ العام الماضي حقيقة لا أستطيع أني يعني أغطيه، يعني جهد رائع جدا، وأدعو الله سبحانه وتعالى أن يجعل في موازين أعماله. رئيس المجلس الطلابي طالب عبد العزيز الشديد أيضا جهده وحرصه على إنجاح مثل هذا المؤتمر ومتابعة ما يحدث فيه وما سيكون فيه لابد أن نثني عليه. رئيسة المجلس الطلابي طالبة مها الغامدي في شطر الطالبات قامت بجهد حقيقة، يعني أقول صعب أن الواحد في مثل الظروف هذه على الأقل يتخيل أنه يمكن أن يقام فيه، لكنه جهد يعني يحسب للجميع. إن ما حسب هذه يعني على الأقل عندنا في الدنيا سيحسب لهم إن شاء الله تعالى في الآخرة. اللجنة العلمية الطلابية للطالب عبد العزيز يعني جهد قد ما يظهر للجميع الآن، قد ما يعبر عن الكثير ممن يعني ينظرون للمؤتمر الآن، لكن هذا ترى ما عقد في خلف الأبواب المغلقة. الزملاء يعني اجتمعوا اجتماعات مطولة جدا ولفترة طويلة جدا، فلهم منا حقيقة كل الشكر. أدعو الله سبحانه وتعالى للجميع التوفيق، وأدعو الله سبحانه وتعالى أن يجعل هذا المؤتمر ناجحا، وأن يكون ثمرته يعني مردها للبلد وللمجتمع ولكليات الطب ولطلابنا في الحاضر والمستقبل. أسأل الله سبحانه وتعالى لكم جميعا التوفيق، وأشكركم جدا على ما قمتم به. بأمان الله.
جزيل الشكر لك دكتور صالح الظاهري على كلماتك المشجعة للطلاب. ننتقل الآن إلى الأستاذ الدكتور خالد ماجد الماضي، وكيل كلية الطب للدراسات العليا، لإلقاء كلمته. تفضل دكتور.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أولا نبارك لكم الإنجاز هذا في إتمام المؤتمر الثالث للأبحاث الطلابية، وحقيقة أذكر يعني كأنها البارحة حينما جاءنا المجموعة الأولى حين البدء في المشروع، ونوعا ما كنت يعني ما بقول ضبطتهم، ولكن حطيت تحديات واقعيه وكانت موجوده في حينها، وما شاء الله تبارك الله يعني قاموا بالمؤتمر الاول وكان ناجح جدا اكثر مما تخيلنا حقيقه. والان النجاح حقها بالاستمراريه الان ما شاء الله تبارك الله، يعني نشد على ايديكم. المؤتمر الثالث جاء في وقت جدا صعب. الدكتور عبد السلام يعني مر بصعاب كثيره وكان مؤقت لها في وقت اخر وبصوره اخرى، وتأقلمكم وتحوير المؤتمر من حضوري الى افتراضي ان دل على شيء، دل على عزيمه صراحه المجموعه القائمه على المؤتمر، واثني عليهم واشكرهم جزيلا على الاستمرار في هذا العطاء. وكما قال الدكتور صالح الظاهري وسعاده العميد، البحث العلمي عباره عن مهاره علميه، مهاره اجتماعيه، العمل في فريق، التعلم المستمر، التأقلم مع الظروف، والقبول بالتحديات، القبول بالنجاح والقبول بالفشل تارة. وفي الأخير هي عبارة عن رحلة لها طعمها الخاص. فهي مهارة تستمر معكم ما بقي الدهر، وإن شاء الله تستمرون فيها كممارسين صحيين لخدمة البلد ورسم السياسات لها، حيث أن هذا الآن حقيقة القطاع الصحي متوجه لرسم سياسات عن طريق الأدلة والبراهين، وليس عن طريق الآراء أو استقطاب الأبحاث من مناطق أخرى. لنا خصوصيتنا ولنا احتياجاتنا في المملكة العربية السعودية، ولن تلبى إلا على أيديكم. أتمنى لكم كل التوفيق، وأشكر جميع القائمين على المؤتمر، وبإذن الله يعني نلتقي على خير.
السلام عليكم جميعا. عبد السلام مدخلي معكم. أحب أنتهز الفرصة هذه وأشكر إدارة الكلية مثلا بسعادة العميد والوكلاء، وفي الحقيقة أحب أوجه شكر خاص للزملاء اللي شاركوا في فعلا تحويل الملتقى إلى الملتقى اللي نحن له يعني متواجدين له اليوم. كان خيار سهل جدا إنه نلغي إقامة الفعالية العام هذه للظروف الغير اعتيادية، واللي نسأل الله إن شاء الله لا تتكرر. في الحقيقة كانوا زملاء على قدر من المسؤولية والاحترافية تضاهي بعض الزملاء اللي نعمل معهم. فالشكر الشديد، الشكر الخاص لزملاء رؤساء مجلس الطلاب الحالي والسابق عبد العزيز ومها ودكتور مانع ودكتور أسارة، والفريق القائم على المؤتمر دكتور عبد العزيز حماد، دكتور لولو صغير، دكتور خالد جديع، دكتور عبد الرحمن العرفج، ولما الزامل. وكل أمل إن شاء الله إنه هذه تكون بذرة ونواة أفضل من السابقة، ولها كذلك فرصة للتحسين والتطوير في الأعوام القادمة. إن شاء الله نبدأ الآن أول سيشن بإذن الله من المؤتمر، اللي هي الأبحاث الشفهية، ومعنا ساعة المحكمين مشكورين لأخذ تقطع وقت من نهاية الأسبوع الخاصة لهم. ونبدأ إن شاء الله بتقديم العروض الخاصة. أسلم الميكروفون الآن للزملاء في إدارة السيشن الأول. شكرا جميعا لكم، وإن شاء الله تصلكم النتائج بعد انتهاء المؤتمر وفي الإعلان الختامي بإذن الله. تحياتي لكم جميعا.
طيب، السلام عليكم ورحمة الله. بإذن الله راح نبدأ اليوم الأورال برزنتيشن. بداية نحب نرحب بالإيفالويتر اللي معنا دكتورة خلود الزين، يعطيك العافية على وجودك اليوم. دكتور محمد الركبان، بروف محمد الركبان، ودكتورة الجوهرة القويز، يعطيكم العافية وما قصرتوا. شكرا لكم. كلمة حابة تبدين فيها دكتورة خلود؟
فخورة جدا بالدكاترة والدكتورات اللي بيقدموا اليوم، ومشتاقة إني أسمع إيش they want to tell to us today.
يعطيك العافية دكتورة. طيب نبدأ مع أول بحث اليوم. راح تكون الدكتورة خلود عفوا الجوهرة المزروع. رقم البريزنتر عفوا رقم الأورال بريزنتيشن هو E4 for evaluation. تفضلي الجوهرة، بإمكانك تسوين شير.
السلام عليكم. I'm الجوهرة المزروع, medical intern from KSU. Our research discussed the association between consanguineous marriage and offspring with congenital hearing loss. Consanguinity is a commonly recognized practice among marriages in the Middle East and may lead to an increase in the prevalence of inherited disorders. Autosomal recessive deafness is the most common form of inherited hearing loss. The relationship between consanguineous marriages and number of children born with sensorineural hearing loss is not clearly defined, and there is no clear indication on the importance of genetic counseling or intervention for high-risk families. Methodology of our research: it is a retrospective cross-sectional study of 189 patients with congenital severe to profound sensorineural hearing loss who were referred to King Abdullah Ear Specialist Center for cochlear implant and fulfill our inclusion and exclusion criteria. We include all pediatrics with prelingual, bilateral, severe to profound sensorineural hearing loss presenting to our center during March 2016 to March 2018. We exclude acquired hearing loss, for example, patients with a history of prematurity, meningitis, hyperbilirubinemia, trauma, or exposure to ototoxic drugs. We also exclude unilateral sensorineural hearing loss and postlingual deafness and children more than 14 years of age. Patients were divided into subgroups based on their parents' consanguinity degree into first cousin, share the same grandparent, second cousin, share a great-grandparent, and more distant cousin share the same tribe, and not blood-related. The result of our research that 131 of our sample were first cousin, 13 of them were second cousin, and 13 were distant cousin, and 32 of them were not blood-related. 20% had family history of hearing loss on the paternal side, and 22% had family history of hearing loss on the maternal side. 83% of parents of children with congenital hearing loss were blood-related. This table shows the prevalence of having more than one child with congenital hearing loss among different degrees of consanguinity. In the first cousin, 38 of them have more than one child with congenital hearing loss. And in the second cousin group, 8 of them have more than one child. And in the distant cousin, 2 of them have more than one child. And in the not blood-related group, 2 of them have more than one child with congenital hearing loss. 31% of blood-related parents had more than one child with congenital hearing loss, while only 2% of not blood-related parents had more than one child with congenital hearing loss with significant p-value. There was no significant difference in the prevalence of auditory neuropathy between the offspring of consanguineous and non-consanguineous marriage. The relative risk of having more than one child with congenital hearing loss in consanguineous parents were 3.5 times higher. Although consanguineous marriage is a common practice in our area, it carries a significant risk of congenital sensorineural hearing loss. Consanguineous parents are more likely to be homozygous for the same trait and therefore increase the chance of having a child affected by congenital deafness. There is significantly higher risk of having more than one child with congenital hearing loss for those who are married to a relative, especially first cousin. So genetic screening, pre-marriages, and counseling should be implemented to those about to marry a relative and for high-risk group. Early interventions for affected children in the form of cochlear implants, speech training, and support for their families during preschool period and at school are of great value. Intensive education about the risk of consanguinity are important to decrease the prevalence of hereditary disorders and increase the public awareness. In conclusion, the risk of having more than one child with sensorineural hearing loss and the offspring from a consanguineous marriage is 3.5 times higher than that of a non-consanguineous marriage. And thank you.
يعطيك العافية الجوهرة على البرزنتيشن الشيق. نبدأ الآن الدسكشن for 2 minutes. نبدأ أول شيء بالجوهر دكتورة غرف الجوهرة الكويز. تقدرين unmute yourself.
السلام عليكم جميعا.
عليكم السلام.
Well done, Johara. You have chosen a very important topic about consanguinity in our culture, which is a big problem, and you have presented it in an excellent way. Well done. I just have a few questions I would like you to highlight. You said this is a retrospective study. Am I correct? Yes. Okay, I would like to know, how did you overcome the problems of missing data with this retrospective study? If you can answer me.
It is retrospective, cross-sectional. So the sample wasn't predetermined. We take all the patient file from 2016, 2018, that the patient were candidate for a cochlear implant. And we include the patient according to the inclusion and exclusion criteria.
Good. Okay, great. So you didn't have the problem of missing data?
It is for one center. So all the patient for cochlear implant who was having bilateral sensorineural hearing loss for us were included, and except the data that the parent wasn't answering us to check for their consanguinity, we exclude them.
Okay, well done. Also, I would like to ask you regarding other studies that have been done here in the kingdom. You did not mention any in your discussion. Were there similar studies? I would assume there are a number of studies about this, isn't it?
Yeah, there was a study in 1995, and it shows high prevalence of consanguinity, but it was not for sensory neural hearing loss only. It is for different degrees of hearing loss. And we assume that in our study, the prevalence of consanguinity will be less or decrease, but as our result shows that it is the same.
Okay, well done, Johara. Thank you very much.
Thank you.
شكرا لك بروف الجوهرة. بروف الركبان إذا عندك أي تعليق تفضل.
أيوة بسم الله. You can hear me well?
واضح صوتك دكتور.
Okay. السلام عليكم. First of all, I would like to congratulate you, Dr. Johara, for this nice topic and presentation. I think you selected an important health problem, which is and with very smart collection of data and dropping of the conclusion. I will appreciate if you could elaborate on what Prof. Johara mentioned earlier about the similar studies conducted national and internationally, and to what extent your result match with them or different from other studies. Now, my other point in relation to the other cofactors of having this hearing loss problem, how to be sure that there is no other cofactor or confounder affect this relation. It's not only the parent relationship. What about the gender relationship? What about the age relationship? What about the other medical problem, and so on? To what extent you be sure that this is the main factor affecting the presence of this health problem? Aywa Johara, can you answer my question?
Yeah, so during data collecting, we review the patient file to make sure that there is no documented any acquired disease. Also, we review the radiology for them for meningitis or any congenital disorder. But we can't like 100% exclude other cofactor. We do our best to make sure that there is no cofactor other than the consanguinity.
Yeah. Now, I think if you are looking for publication, and I think it is worth to publish such article, you need to elaborate more on the demographies of all groups, and be sure they are almost with the same cofactors. There is no other factor affecting the differences between the four group with different relationship. My second question, that what is then your recommendation in relation to this conclusion? Do you feel that any relationship should be avoided to avoid this hearing problem, or you have specific indication for those high risk group who we will advise them not to get married?
We want to have a clear indication about the pre-marriage counseling, and for also the couples that already married, so they have a clear decision of having another child, and if they have another child, so will be early intervention, because they have a more chance that they have another child with a congenital hearing loss.
Yes, and it is clear there are two factors according to your result. One of them is the relationship, and the second thing is the presence of hearing loss in the family. We could conclude primarily from your work that if any family has two factors, I mean, having a hearing problem run within family, it's better to avoid the get marriage for the first degree of consanguinity. طيب شكرا لك يا جوهرة، موفقة إن شاء الله.
شكرا.
شكرا لك دكتور محمد الركبان. دكتور خلود الزين، إذا عندك أي إضافة تفضل.
ما شاء الله تبارك الله، وفوا وكفوا.
ممتاز، يعطيك العافية دكتورة، وشكرا للجوهرة المزروعة على البحث هذا. بس ملاحظة للإيفالويترز، احنا عندنا شوي كذا بالوقت منحدين على 10 minutes، فبنخلي للأورال presentation will take 8 minutes and 2 minutes for discussion، بس عشان ما نتأخر على الأذر presentation بعدنا.
يعطيكم العافية جميعا، يعطيك العافية بروف الجوهرة، بروف محمد، دكتورة خلود. ننتظر منكم الإيفالويشن الآن، إذا ممكن تسوون لها سبمشن. وصلنا حقك دكتورة خلود، لكن ننتظر الباقي. يعطيكم العافية. ممكن نبدأ باللي تالي على بال ما تسوون سبمشن.
ممتاز. طيب النكست برزنتيشن اللي هو دكتور عبد الرحمن العرفج، الكود حقه E5.
بس لحظة لو سمحتي دكتور، أعطني بس 30 ثانية لو سمحت حتى نركز مع البرزنتيشن لو سمحت.
أنا مع الدكتور الركبان إنه بس نحتاج دقيقة واحدة أو أقل بعد.
تفضل دكتور. نقدر نروح للبرزنتيشن الثاني دكاترة؟
يلا أنا أوكي I'm done.
ممتاز، يعطيكم العافية. دكتور الجوهرة
تفضلوا.
طيب يعطيك العافية. دكتور عبد الرحمن تقدر تفضل الحين.
السلام عليكم.
عليكم السلام.
واضح الصوت والصورة؟
واضح، تفضل.
طيب. السلام عليكم. My name is عبد الرحمن العرفج. I am 6th year medical student in Imam عبد الرحمن bin Faisal University بالدمام. I will present the case, the research with with Dr. Anjud Abdelkader. We talk about the knowledge, attitude, and practice of swaddling among Saudi Arabian pregnant women. Okay, this is the outline. And first of all, we talk about the DDH. Definition of DDH is developmental dysplasia of the hip. It is a disorder that characterized by abnormal development of hip joint. It includes a spectrum of physical and radiological findings. The incidence of DDH was reported in Saudi Arabia 3.5 for every 1,000 live birth. Unfortunately, there is no specific etiology of DDH was reported. However, there is many factors that strongly associate with development of DDH. The definition of swaddling is a habit of wrapping baby body using a long strip or many bandage, and it's common traditional in Middle East and Saudi Arabia. We have wrong swaddling. It is suggested to be the top of the list of risk factors for progression, the DDH. Our objective or our aim is the measure of prevalence of newborn swaddling among Saudi pregnant women, know the reason and that newborn are swaddled by their mother, assess how far Saudi pregnant women know about the swaddling and DDH. Our methodology is a cross-sectional study was conducted at King Fahd University Hospital Khobar in 2016. Sample size was 200 Saudi pregnant women attending visits at OB/GYN clinics. The questionnaire was designed by investigator and validated by expert panel. So our results, 200 pregnant women, the mean age was between, the mean was 30 years old and range between 31 to 40. Most of participants, which is 90% heard before about the swaddling from their families, and only 10 to 11% of them know the complication of DDH with pelvic osteoarthritis, which is very low. So the result, we have 94% use the swaddled the body as a whole, and only 6% use swaddled only has a shoulder, which is this is the right way. This is the good way, which is the low swaddling, which is the healthy way to swaddling the baby. This is the table results. Most 55% were high school educations, 54% were housewife, 65%, and which is most of them were multigravida. 91% of multigravida, they already swaddled their children. 49% of them, they do it to calm the newborn. 37% of the mother believe that DDH was caused by medical error. 46% was believe that there is beneficial for the newborn. But 45% are actually not aware of exact cause of DDH. The effect of swaddling on DDH, 90 of participants of 200, they said always good, sometimes good, they said only 75 of participants. Most of them, they do it between 3 to 4 months. So the discussion, the woman interviewed in this study was found to had many misconceptions about DDH. 85% of participants in this study believe that swaddling is beneficial for their babies, in contrast to the reported study in the literature. Swaddling increasing the progression of DDH in affected hip. Not any swaddling, the wrong swaddling, which is the hip and the swaddling the hip and also the shoulder and hand. 48% of participants believe that DDH often caused by injury to the hip. On the other hand, 37% believe that it happened because of a medical mistake. In the study in 1968 found that 6 weeks or more swaddling use is enough to negatively develop dysplasia or DDH. This finding makes the risk of DDH higher in babies who are swaddled. In 2012 stated that one of the causes that let mothers stop to swaddle their baby that think or thought about the risk of DDH. On the other hand, the most frequent causes of swaddling were traditional practice and its benefit in calming baby while sleeping. Again, this is the right swaddling, not wrong swaddling. Some of well-known harmful effect of swaddling, as the research said, there's hyperthermia, pneumonia, DDH, and sudden infant death syndrome, which is common in infant where on side or front. However, loose swaddling, which is this right way, this is what we want in our community, excluding the head while the baby is on her or her back during a certain time of the day, will not risk the baby and in fact allow normal development and other benefits. This study recommends the instruction have to be given to all mothers regarding the best way of swaddling. So try to benefit the baby as much as probably. Finally, the discussion. Another study was conducted in 2017, stated that swaddling has good effect on newborn, which help calm the baby and decrease crying, this is the right way in this figure. This is the right swaddling, loose swaddling in the hip, for the hip. It can be also complementary therapy with pharmacological management to get optimal effect after painful procedure. In conclusion, according to the result of our study, there is many misconceptions regarding DDH, and the right way of do the swaddling and found in our community. Recommendation: awareness regarding swaddling and positive correlation should be raised among the Saudi society. So the study suggests distributing brochures that are taking about the best way of swaddling in obstetric clinic and prior to discharge from hospital after delivery. This is my references, and this is yeah, this is the final slide. This is the wrong swaddling. It's not the right swaddling. Sorry. Thank you.
بروف الجوهر تفضلي.
شكرا جزيلا دكتور عبد الرحمن. صراحة you have chosen a very important topic and a topic that we know that needs a lot of health awareness. أنا سؤالي, why did you choose only a pregnant woman? Why didn't you choose, let's say, because pregnant and others probably they do the same. They use this swaddling. Okay, why did you choose specifically a pregnant woman? This is the first question. The other question is, so your recommendation is to use the good swaddling. This is your recommendation,
yes.
The good swaddling. So, and avoid the bad swaddling, which includes the head, right?
The hip, yes. Not the head, the hip.
The hip.
Yes.
You mean without covering the hip? You mean just the upper part without pressing it
yes.
too tight?
Usually the swaddling is be tight in the shoulder and the hands.
And the lower part, yeah.
Yes, and the lower part, it's they should be loose, as we say, in this
right.
picture.
Okay.
Like
okay.
this one.
Okay. Okay. Fine. So if you can answer the first question.
I don't know صراحة, ما كان في شيء يعني يخلينا or let us to take another, but إنه كان تركيزنا على البريجننت لأن هم اللي غالبا يكونون بداية الحمل أو إنهم يعني أسهل لنا في أخذ المعلومة أو أخذ الكويستشنير لما نكون قاعدين معهم. يكون مثلا الاذر بيكون الفاريشن، فكرنا الفاريشن حق البحث بيكون واسع شوي، بس لما يكون احد مثلا جرب او مثلا احد عنده بيبي بيفور هي والله يعني عنده المشكله هذه او عانى منها، فيكون اكيوريت لاجابات البحث. هذا اللي كان اتوقع السبب يعني.
صحيح. سؤالي الثاني دكتور عبد الرحمن، بالنسبه للكويشنير، انتوا اللي سويتوا الكويشنير، you formulated your questionnaire, right?
Yes.
Okay. طيب did you validate it? Did you what did you do? How did you make sure that the questionnaire is really valid?
We do it with Dr. Prof. Sadat. He's an orthopedic surgeon in our university. Actually, he validated, not me and my colleagues. So I don't sure about how they did it, but يعني this is
okay. Okay. Okay, thank you very much. Thank you.
Welcome دكتور. شكرا لكم، يعطيكم العافية جميعا.
كانت في أسئلة هذه بس لأننا متأخرين بالوقت.
طيب عبد الرحمن, sorry, can you go back to the first graph you show, or first the first one, the effect of swelling on baby. Well, this one, yes. What is this? Always good, sometime bad. Is this the response of the mothers?
Yes.
Mothers, they said always good. They are 90%, 90+%.
No, 90 of 200% participant.
Oh, this is participant, not percentage.
Yes. Sorry, I didn't write that.
Now, are you measuring the knowledge or practice? Both?
No, knowledge. As they said, they hear from families. So we ask it why and how good you يعني ليش قلتوا اوكي، يعني ليش سمعتوا من اهلكم وشفتون يعني، فهذا من الاسباب يعني. بس قالوا لما سالناهم ليش كان good، اغلبهم كانوا يقولون they don't know as here causes of swaddling، يعني ما كانوا يعرفون ايش السبب يعني. Most of them يعني.
Okay, that means you are measuring their background, their knowledge, rather than their practice.
Yes.
But why they said you said 98% they are doing good swaddling, and you said, is this practicing or practice, measure of practice or measure of knowledge?
Where is it, doctor?
somewhere. He multi-gravida here in this table.
Yes, we ask multi-gravida specifically because they already did the swaddling. Prime gravida is first time. So we take the 130 participant, as we said in the red here, okay? And we take and we ask him again, did you swaddling there before? They said yes. 91% of 130, they said yes, we do it. So why you do that? So to count their newborn. Is it good or not? You go, yes, is it good? Why? They don't know.
Okay, then you are measuring both their knowledge.
Yes. Yes. I think you mean only the effect. Yes, we both measure both practice and the effect. شكرا لك دكتور.
يعطيك العافيه دكتور. دكتوره خلود اي اضافات؟
بس سؤالي فيصير السامبل تبعكم فقط الwomen who are in the waiting room of the OB صحيح؟
Yes.
So it's يعني that's your sample, the waiting room.
Yes.
Over a period of time.
Yes. By questionnaire.
Okay. Thank you.
Thank you, دكتور.
شكرا لك دكتور عثمان يعطيك العافيه وشكرا للدكاتره. شكرا لكم بالايفالويشن الحين على بال ما يدخل next presenter.
شكرا لكم جميعا.
يعطيك العافيه. دكتورة منيرة العمري بإمكانك تسوين شير سكرين. دكاترة جاهزين؟ نبدأ باللي بعده.
أنا بالنسبة لي جاهز، تفضل.
تفضل يا دكتورة منيرة.
Assalamu alaikum. I'm Munira Al-Umari, medical intern at King Khalid University Hospital. Today I'm gonna present our research, chorioamnionitis, clinical predictors and obstetrical outcomes on behalf of my team, Dr. Nada Al-Aid, Dr. Maria Arafa, Dr. Ghada Al-Malki, Dr. Lama Shwerekh, and Dr. Khalid Akur. So first of all, as we know, placenta plays an important role in pregnancy by oxygen and nutrition supply to the ingrowing fetus within the womb. So pathology associated with placenta can be indicative of a decline in oxygen supply to the fetus. However, at times of compensatory mechanism are undertaken by the placenta to counteract fetal hypoxia. So chorioamnionitis is one of these compensatory mechanisms that is often seen as hyperplasia of the chronic villi. It was first described in 1984 on the basis of histopathological findings that are 10 or more of the terminal villi having 10 or more capillaries and 10 or more fields of 3 or more random non-infarcted areas of the placenta. So placental pathologies, even though complex and mysterious in terms of mechanism and coexist with varied maternal and fetal situation, the shortage of literature elaborating the complexity and the overlaps of the placental pathology explains the needs of an elaborated research to explore the maternal risk factors that lead to chorioamnionitis along with pregnancy outcome. So with this background, the current retrospective study explored the associated maternal risk factors along with pregnancy outcomes in chorioamnionitis. So for our methodology, as I said, it was a retrospective study carried out in King Saud Medical University City between September 2015 to December 2018, using the past medical records of pregnant women. A total of 78 pregnant women were reviewed for the study with cases of 26 and control of 52 in the ratio of 1:2. Our inclusion criteria was pregnant women visiting King Khalid University Hospital antenatal clinic or delivered at King Khalid University Hospital. So our study aimed to find out the maternal risk factor which might have led to chorioamnionitis and further how the development of chorioamnionitis may be associated with pregnancy outcome. As for the results, as you can see here, table number 1, the association of maternal risk factors with chorioangiosis among cases and controls. We measured the age of the mother, BMI, gestation type, gravida, and parietal. So these were considered as the potential risk factor that might have led to the development of chorioangiosis. But as you can see, the p-value here, none of these were statistically significant. But in the incidence of chorioangiosis, as you can see here, were less among women who are having twins, which was similar in other studies. Plus, the relation of multipara has been seen in chorioangiosis has been seen in relation to multipara, as you can see here. But in the current study, parietal did not attribute much to the significance difference was seen among cases and controls. This means that none of the hypothesized risk factors were found to be significantly, statistically significant for the development of chorioangiosis. For the second table, the association of pregnancy outcomes with the occurrence of chorioangiosis among the study participants. As you can see this graph, we have the abortion, abortion in current pregnancy and the babies who were born alive. We have the cases in light blue and controls in blue. We have seen that the fetal outcomes in relation to chorioangiosis to be significantly affecting the pregnancy outcome, like the number of abortions, as you can see here, was 5 in relation to the controls was 0, with a p-value of 0.003. However, the number of IUFD cases and controls were similar among both groups. As for the gestational age at delivery time, cases and controls, cases in light blue, control in blue, we have the difference in the proportion of the study participants belonging to the preterm, early term, full term, and late term. There was a statistically significant p-value of 0.3. Preterm delivery reported 16 cases were more susceptible to chorioangiosis, with a significant difference between cases and controls, which is again relatable to other findings in other studies. As for the mode of delivery, we have the cesarean versus the vaginal spontaneous induced delivery cases and controls. Cesarean delivery was higher among chorioangiosis cases in the current study, which correlates with the past evidence. But we have found that there is no significant finding was seen between the cases and control, as you can see here, with the majority of pregnant women obtaining the same. And we found out that this is due to the fetal causes of cesarean section. As for the Apgar score at 1, Apgar score at 5, the differences in the proportions of the participants with the neonatal Apgar score of 1 score at 1 and 5 minutes was statistically significant, with the p-value of 0.048 here and 0.06 here respectively. Of the 12 neonates having the Apgar of 0 at 1 and 5, as you can see here 8, and here we have them at 9. Another significant finding is relative to the importance in cognizance with evidence-based literature is the lower Apgar score, which was described traditionally in the previous studies. For the limitation of our study, first of all, the study was a retrospective study, so some of the information gathered from the fresh placental informations were lacking. And the second thing, we have the cases and controls were not matched evenly, so the results cannot be extrapolated on the larger population. And the risk factors that we have hypothesized to be the risk factor were not found to be statistically significant with the development of chorioangiosis. Thereby, the identification and attributing factors in depth and multitude could have been more useful. And in conclusion, the current study has been useful in underlining some of the key factors attributing to chorioangiosis with fetal and placental outcome. However, we need a detailed research that can be done to elaborate and distinguish the overlapping features of and causes of chorioangiosis. In conclusion, so as I said, none of the potential risk factors were found to be significant, but however, we found that the chorioangiosis was found to be associated with higher rates of abortion, poor Apgar score at 1 and 5, as I said before, it was 0, and a more preterm birth. And thank you if you have any questions.
يعطيك العافية منيرة على البرزنتيشن الجميل هذا. دكاترة عندنا دقيقتين if you have any questions تفضلوا.
دكتورة إذا سمحتي على أي أساس اخترتي الكنترول؟
Okay, the control, they were matched على أساس the age of the cases. So we matched them with the maternal age.
And what were your exclusion criteria?
Our exclusion criteria was any pregnant woman with insufficient data or no placental pathology that we can compare with.
Okay.
اوكي
سوري تفضل دكتور.
والله تفضلي انت استاذتي.
الله يسلمك. ابدا انا بس عندي سؤال بسيط صراحه. اول شيء احب اشكر الدكتوره منيره صراحه. your presentation is excellent ما شاء الله, and you had very nice graphs, very nicely done, and you discussed your limitation. Even all the questions that we wanted to ask you just mentioned in the limitation. هل تعتقدي دكتورة منيرة إنه you have other variables that you should have considered and you didn't consider?
I believe maybe chronic medical conditions, diabetes, hypertension, that things that may affect the placenta.
Exactly. What about smoking, antenatal fetal issues, other problems? I think there are a number of variables which were not included in your study.
Yes, I agree.
This is a big limitation, and you have to find a way to, I don't know how to correct it, but inshallah it will be published, but they might raise these questions, and there are some variables you did not consider. Okay?
Okay.
Thank you.
Okay, I think the point mentioned by Prof. Johar is very important. I was planned to also raise it, because on what basis you selected these factors to be the variables for comparison. I have just a quick question and one suggestion. Now, how do you diagnose this patient? The patients, and how do you make them eligible to be listed as a patient with chorioamnionitis? Is it radiological diagnosis or postpartum?
It's postpartum histopathological placental diagnosis.
Okay, pathological postpartum.
Yes.
طيب لو رحتي للجرافز اللي انت عرضتيها دكتورة منيرة, اي واحد منهم الcomparison between الcontrol and case, I prefer, if you are planning, can you go to any one of them, please? If you want to publish or to present it in the future, and correct me, can you go to any one of them?
It's not shared with you, doctor.
Okay. لا, اللي طالع عندي الصفحة الأساسية بس اللي هو العنوان.
تمام, والآن.
Just quickly, this one, for example, if you compare between no abortion, the case, and control, you are using numbers here. And I prefer to use percentage, because the percentage will make it more clear. You cannot say there is association or there is no association while you are comparing between numbers. The percentage will make it clear, more clear, because what you are mentioning is higher. Actually, in the graph, it is lower. Yes, here in the table, it's good. But while in the graphs, I think better to use the percentage in comparison. شكرا يا بنتي.
شكرا لكم دكاترة على الايفالويشن، وشكرا دكتورة منيرة العمري على البرزنتيشن. بإمكانكم الحين تقيمونها ونبدأ بالجاي بعد نصف دقيقة. دكتور أسامة زيتون، بإمكانك تسوي شير للبرزنتيشن حقي. تفضل دكتور أسامة.
بروف الجوهرة احنا بانتظار تقييمك. تمام،
أرسلته.
يعطيك العافية.
يلا we are ready. بسم الله.
السلام عليكم. المعذرة كان الميكروفون مغلق. السلام عليكم ورحمة الله. My name is Osama Zaitoun. I'm a current medical intern from Sulaiman Al Rajhi University. I'll be presenting today on behalf of my colleagues short presentation about our review article entitled Management of Benign Prostatic Hyperplasia by Combinatorial Approach Using alpha-1 adrenergic antagonists and 5-alpha reductase inhibitors. For a small intro, the main available treatments that are currently available for benign prostatic hyperplasia are alpha-1 adrenergic antagonists and 5-alpha reductase inhibitors. Anticholinergics and phosphodiesterase 5 inhibitors are also used, but we are more concerned with the alpha blockers and 5-alpha reductase inhibitors to do their common use. Recent studies support the combined therapy approach using 5-alpha reductase inhibitors and alpha blockers to treat the lower urinary tract symptoms in patients with benign prostatic hyperplasia. Our methodology, we aimed to review BPH management in select group of randomized controlled trials that assessed combination therapy with alpha blockers and 5-alpha reductase inhibitors and compared it to the monotherapy with either drug alone with respect to the safety and efficacy. A total of 6 RCTs were included in our review. The methodology is not completely presented here as we have only done mesh research via PubMed. We have chosen 5 common keywords and filtered the results for all the clinical trials to conceive these 6 RCTs. We have not done an extensive literature review as it was beyond the scope of our mini narrative review. The 6 RCTs were reviewed for clinical progression as manifested through International Prostate Symptom Score, quality of life, post-residual urinary flow rate. We are most concerned with International Prostate Symptom Score as most of the studies have used it to compare the therapies. The results of our review markedly favored the treatment groups that received combination therapy of both alpha blockers and 5-alpha reductase inhibitors when compared with either groups that receives either of the monotherapies. There was a synergistic effect of the drug combination in patients who have an enlarged prostate more than 30 ml. This was the main inclusion criteria in most of the RCTs to have an enlarged prostate more than 30 milliliters. Here are the table that summarize the 6 RCTs that we have included, including the methods that they have used and the results of each RCT. Most of the results were, as we mentioned, favoring the combination therapy, except the oldest study at 1998 that have seen that the alpha blockers, especially alphozine in this study, was better than the combination therapy. When we dig more to see the reason there, we have constructed this graph based on the follow-up of each study. The name of the study is here, the follow-up period each study have done. And then the mean decrease in IBBS score, International Prostate Symptom Score, as we mentioned previously. which of these the combination or the reductase or alpha blockers have decreased the international prostate symptom score more than the other. We can clearly see that the combination therapy is favored in these 3 studies, except the oldest study, and we can trace it back after evaluation to the short follow-up period. We can see here it's 6 months in comparison to 2 years, 4 years, and here 2 years. Maybe the short follow-up period was not enough for the combination therapy to be better than the alpha-1 blocker. As we know, 5-alpha reductase needs time to show its effect. Only 4 studies compared international prostate symptom score and are presented in this graph. Other studies, the remaining 2, used other methods like the quality of life and the post-residual prostate urine flow. Conclusion, beside being pharmacologically more effective, combination therapy such as the FDA-approved Jalene, containing tamsulosin and dustride. Tamsulosin, the alpha blocker, and dustride is the 5-alpha reductase inhibitor, is also more cost-effective, and the side effects resembles that of monotherapy. Same side effects with no other extras adverse effects. With excellent long-term outcomes, combination therapy can be started in patients found to have prostate enlargement, causing moderate to severe symptoms. Our study was February, recently published in European Journal of Pharmacology. And I want to thank you all for your kind attention.
يعطيك العافية أسامة. الدكاترة بينكم ممكن تجاوبون لنا دقيقتين للدسكشن. يعطيكم العافية.
دكتور أسامة، معلش في شوية توضيح بس. You are talking, you're doing a systematic review ولا لا؟
لا دكتور, it's a narrative review, mini narrative review, and not, yes.
Not systematic.
Yes.
Okay. So it's a review. يعني في البداية كأني فهمت إنه you took all the studies that were looking at this problem and you studied over a certain number of years ولا لا؟
لا, we have chosen a couple of keywords.
You selected, yes, I know, but through that, but you did not include all the studies. You selected some of them, right?
Yes, we selected all the studies that were in our keywords, but we have not done an extensive literature review as it was beyond the scope.
Okay. والله يعني this is very interesting study. والطريقة that you presented very well done. وما شاء الله يعني it's already published in the European Journal of Pharmacology. فما شاء الله, let us congratulate you for that.
Thank you, Doctor.
Well done. Okay.
أيوة أسامة, I also second what Prof. Johara mentioned. يعني it's really interested. It's very nice that students now they are going toward this type of studies, review articles, and maybe meta-analysis soon, inshallah. I'd like to congratulate you too. I'd like to ask one more step to in the future maybe whenever you want to present. It's good to compare between the 6 studies or the one you collected in a more analytical way, including the number of patients, the overall results, instead of just dropping the conclusion of the study. We need to know to what extent their patients are similar here and there, and to what extent the overcome result from each one of them will be similar. I know that will move you toward meta-analysis, but it's good to compare between the input, at least, of these different articles. My question here, did you went through critical appraisal of this randomized control trials before you start to drop your conclusion and compare between the results?
Thank you, Doctor, for your input and your suggestions. It's much appreciated. Yes, we have gone through the first step. We have seen all the randomized control trials and make sure that all of them are randomized, all of them are having specific criteria without any duplications. And we have tried our best to include all the RCTs from our keywords that have included all of the comparison that we were looking for.
Is there any similar studies published in these aspects? Any similar evidence-based guidelines or meta-analysis published in this aspect? Are you aware?
Yes, I think there was, I've seen recently a meta-analysis that was published. It included also other combination therapies, because there's also combination therapy with anticholinergics and 5-alpha reductase and all of that, other types of combination therapies. So there was also another meta-analysis, and they also concluded on this combination to be the most effective on clinical progression.
Yeah, I agree. And also there are some clinical guidelines referring to the same conclusion. It's worth to mention that in your discussion later on. شكرا يا دكتور.
يعطيك العافية دكتور، الله يسلمك.
شكرا لكم دكاترة، يعطيكم العافية. إذا حابين ممكن ناخذ بريك من 8 to 10 minutes الحين.
والله جميل.
لو حابين نكمل.
ممتاز، ناخذ بريك لو سمحت.
خلاص يعطيكم العافية. We have a 10 minutes break، يعني فيا ريت ترجعون by 5:26 دقيقة كذا تقريبا. يعطيكم العافية جميعا. ناخذ بريك الآن ونرجع على الساعة 5:26 دقيقة. شكرا لكم. السلام عليكم ورحمة الله. البرزنتيشن الجاي راح يكون الدكتور محمد الدماس. دكتور محمد بإمكانك تسوي شير سكرين بس ننتظر تأكيد من الإيفالويتر. بروف الجوهرة موجودة؟
أيوة موجودة، تفضل.
يعطيك العافية دكتور. بروف محمد.
يعطيك ألف.
دكتورة جواهر.
السلام عليكم.
عليكم السلام.
الصوت واضح؟
واضح صوت، تفضل. ثواني بس نتأكد بس. دكتورة خلود موجودة؟
ايوه موجودة.
يعطيك العافية. تقدر تتفضل دكتور محمد.
السلام عليكم جميعا. معكم محمد دماس, medical R1 من KSUMSC. Today I will talk about prevalence and predictors of obstructive sleep apnea in large bariatric surgery cohort, which was supervised by Professor Ahmed Bahmam, and it was conducted in the University Sleep Disorder Center in King Saud University. First of all, obstructive sleep apnea is characterized intermittent, partial, or complete upper airway collapse during sleep, leading to sleep fragmentation, hypoxemia, hypercapnia, interthoracic pressure oscillations, as well as the increased sympathetic activity. And it is well known that obesity is a risk factor for obstructive sleep apnea. When combining the two, obstructive sleep apnea and obesity are considered risk factors for different diseases, such as cardiovascular disease, hypertension, diabetes, etc. As obstructive sleep apnea increases the likelihood of adverse events in post-operative period, diagnosing and treating it forms an integral part of pre-operative workup of morbidly obese patients undergoing bariatric surgery. OSA is suspected on the basis of characteristic history, snoring and daytime sleepiness, and physical examination like increased neck circumference. However, overnight polysomnography is needed to confirm the diagnosis. Treatment of OSA include weight loss and administration of continuous positive airway pressure, CPAP therapy. Weight loss by non-surgical means non-satisfactory and non-sustainable. Bariatric surgery is therefore a reasonable option for weight reduction for patients with clinically severe obesity. Unrecognized OSA, especially in those patients receiving abdominal surgery, has influenced preoperative morbidity and mortality. Our aim in this study is to assess the prevalence and identify the predictors of OSA among patients referred for bariatric surgery. And this study was approved by our IRB, and all patients included gave informed written consent for their participation in this study. Our methods here, we have taken a total of number of cases 5,800. These cases all the cases was referred from outside the center. We have included subjects whose BMI is more equals or more than 30, and also who get referred from bariatric surgery, and we got a number of 265, and those subjects, the 265, all of them underwent a sleep study, and we have confirmed that OSA, a total of 153, number of 58%, and 42% of non-OSA. And our population, 265 patients, 136 of them is men, and the rest is women, with a mean age of 30 years and a mean BMI 47.4, and all of them again underwent sleep study. And our prevalence here showed 58%, and those patients were predominantly males, 66%, and the mean apnea-hypopnea index of those patients is 62 events per hour. And comparing with obese subjects without OSA, non-OSA patients, showed that OSA subjects were approximately 10 years older and had higher BMI, neck circumference, and waist circumference. And moreover, the prevalence of comorbidities like hypertension, diabetes, and dyslipidemia was significantly higher in patients with OSA. In this table, we are showing the variables are considered statistically significant. We have the age, BMI, neck circumference, and waist hip to ratio, gender male, smoker, snoring, and hypertension, diabetes, and dyslipidemia. And moving to the discussion, after we have studied the 265 patients with the sleeps and underwent sleep study, we have found our prevalence 58%, and also and 153 among these patients diagnosed with OSA, 66% were males with mean apnea-hypopnea again in 62 events per hour. OSA patients were approximately 10 years older. The association between increasing BMI and the severity of OSA is well recognized and could again be confirmed by our data. In our study, neck circumference proved to be predictive for OSA. The increase in neck circumference leading to an increase in apnea-hypopnea index is in line with other study also, and our value of 16 inches matches the value reported. Studies showed that waist circumference is associated with increased risk of obstructive sleep apnea. In our study, the waist circumference also was statistically significant, and we found that comorbidities like, again, hypertension, diabetes, and dyslipidemia was significantly higher in patients with OSA, and we conclude that OSA was highly prevalent among patients referred for bariatric surgery, even after consideration of co-founders like increasing age, male sex, and BMI remain as independent predictors of obstructive sleep apnea. Taking home message: bariatric surgery patient should be screened for OSA. Thank you very much for listening.
شكرا للدكتور محمد الدماس على البرزنتيشن. دكاترة عندكم 2 minutes لأن we're running out of time بس. يعطيكم العافية.
شكرا يا دكتور. Very simple question. Why you only took your sample from the patients who are referred from bariatric to do sleep study? But why the other specialties weren't included if they are eligible to have bariatric surgery?
Because our aim is to see if there is an association and if there is increased prevalence in the bariatric surgery population themselves.
But they're all referred to the pediatric clinic, isn't it? When you showed that algorithm?
Pediatric?
Pediatric.
Yeah. All of them referred from bariatric clinic, yes, all.
You didn't get my question, بس ما في مشكلة عشان بس الوقت. تفضل.
I think, دكتورة Prof. Jawhara, اسمحي لي بس, and I have also a question related to Dr. Khulud question. And if you go back to the distribution of your population, the graph اللي وريت لنا الالجوريثم هذا, أيوة. يعني now the targeted population, which is 5,800, some of them below 30 and some of them above. Both of them refer to bariatric surgery or not?
No. The patient who BMI is more than 30 equals or more than 30 was 2,400.
Okay.
Unfortunately, there was no patients, their BMI less than 30 got referred from bariatric.
Okay, now those who is above 30 BMI, some of them referred from bariatric surgery and other referred from other specialties. Referred where?
like from different specialties. يعني,
You mean where referred where?
To the sleep center.
Okay, and you did not present their result. We don't know. We have no control to compare.
You mean by comparing the referred from different specialty and
yeah, this is the question, Dr. Khulud. Why you did not include these whose high BMI, where they are referred from other specialties? Why they are not including within the study?
Yes, because our aim here again, we were only specify the patient who came from pediatric clinic only. I'm not sure why. يعني,
then you are not comparing between patients. You are comparing between clinics.
No.
Type of clinic. Okay, because you know this is very important confounder. يعني. طيب, can you go to the last slide? Your recommendation, معلش يا دكتور. Based on what you make this recommendation? And I don't see, because all of your patients already came from bariatric surgery. You said bariatric surgery patient should be screened for OSA. How you came with this conclusion while all your patients from the beginning, they are coming from the bariatric surgery?
Because unfortunately, there's some bariatric clinics, they are not considering to refer their patients to sleep clinic. And after we found the evidence of the high prevalence and the highly prevalence among these patients, we are recommending to all bariatric surgery patients because of the obesity. And the link of obesity and OSA, it will document it that.
I get it, because you have high percentage of patients who already have sleep apnea. That's why you want them to be investigated.
Yes, confirmedly diagnosed OSA.
Maybe the other reason that those patients who's actually referred on bariatric surgery because they have some respiratory symptoms. That's why they refer them, and that's why their prevalence of sleep apnea were high between this group. Okay, I'll leave the other question for Professor Johara.
Thank you very much, Dr. Muhammad. A very nice presentation. Can you go back to the predictors, please?
Yes.
Okay, fine. Right. So you have a number of predictors. Do you think you have missed any of the predictors?
You mean
what about, for example, I'm just wondering, what about example, you have said that the neck circumference is a good predictor of the obstructive sleep apnea, right?
Yes.
Okay, so as I can see here, you have a number of significant factors related. Why did you say only the neck circumference? You have the age here, you said the age. Then you have the hemoglobin, you have so many things. What I'm trying to tell you is, when you have so many predictors, what you can do is do something called multiple regression model to find which one is stronger and to remove the confounders if there are any confounders as much as possible. So you can tell which one is really has the most effect, okay? So this is something you probably can do to improve your studies, doing something called multiple regression model. The other thing, I think you have missed some variables which you have to recheck again. And I think one of them, I cannot remember, Yani, but I think the enlarged tonsils can result in similar problem. Also, the other thing that I wanted to ask regarding, you mentioned that they have done something called polysomnography, right? Yes. To check that the diagnosis is correct. Am I correct?
Yes, doctor.
All of them, they have done that, right?
Yes,
I think you should also mention a little bit about this test and tell us about the sensitivity and specificity. And because if you depend on only this test, and we don't know how accurate this test is really. For me, for example, I don't know. So it's very important that you mention it. or you can mention the predictive value of this test. So as we can say whether it's really very accurate diagnosis or not. Okay.
Thank you very much. Thank you.
And totally, I agree with my colleagues' comments, Dr. Rukban and Dr. Khulud. Thank you very much.
Thank you.
It's a good study, but needs little bit تعديلات بسيطة. الله يعافيك.
يعطيكم العافية دكاترة، وشكرا لك دكتور محمد على البرزنتيشن. نعطيكم بس نص دقيقة للإيفالويشنز وبعدها راح يبدأ الدكتور أحمد اليحيى للبرزنتيشن. دكتور أحمد you can share your screen.
السلام عليكم جميعا. الصوت واضح؟ تمام. This is Ahmed Al-Yahya. I'm a medical intern. Today I'm going to present a novel multipod drainage catheter to enhance fluid drainage and an in vitro evaluation. As you know, catheters can be applied to multiple body systems, such as the cardiovascular, as in cases of central venous catheters, CNS, as in VP shunts, chest tubes, or Foley's catheter. Here are some different applications of the catheters. One of the main issues that faces catheter application and lead to catheter failure is mechanical obstruction, which is mainly attributed to catheter clogging. Here is an image showing catheter clogging by debris. As you can see here, the pores are clogged. This is an axial view showing catheter clogging. All of this would lead to increased complication and would further increase the cost by requiring catheter replacement, for example, or even requiring a revision surgery. Adding to that, it will lead to a poor patient experience. Previous design attempts have tried to solve this issue. One of them has proposed a multiple catheters wrapped in a sheet. Another design used a large pore catheter. Another design used multiple catheters connected to a central catheter. All of which had some drawbacks that can be either attributed to the fact that they require larger wounds to insert, difficult to insert and guide, suboptimal surface area. None of which has had published superior data. So our solution is to enhance drainage using larger surface area and using a catheter that can be easily inserted and controlled remotely by a semi-rigid stylet, and to be able to be inserted through a long distant tubular structure. This is our catheter. As you can see here, this is the central large catheter. Within that catheter, there are 4 internal drains connected to a connecting piece through which it has an opening, as you can see here. That opening is specified for the stylet to be attached to it, so the stylet can deploy and retract the catheter post-insertion. This is our catheter after deployment. And as you can see here, the internal drains have small pores that would further increase the surface area of the catheter. So regarding the ideal solution, hypothetically speaking, our catheter has a larger surface area, so it enhances the drainage capabilities. It can be easily inserted and can be remotely controlled via the stylet. it can be inserted over long tubular structure as well, such as the GI or the urethra. This is the patent by Prof. Ayman Al-Jazairi. And moving on to our in vitro evaluation. To prove our concept, we aim to assess the drainage capabilities and resistance to a clogging medium. These are the catheters that we used. This is the multi-pod catheter, our catheter, and this is an open tip control catheter, and this is a closed tip control catheter. Both of these catheters are for control. We use two test models. One is clogging medium, and the other is non-clogging. The non-clogging medium is basically 1 liter bag of distilled water. The clogging medium is 1 liter bag of distilled water, adding to it a weighted amount of cotton and sodium polyacrylates, which swells up when it gets contact with the water, increasing the viscosity of the fluid in an attempt to simulate body fluids. Here are some of the pictures. As you can see here, the viscosity is different than the non-clogging medium. To control our study, we controlled all the variables except the catheters that are being used. We used the same pressure of suctioning. We recorded the drained volume every 30 seconds, and each catheter underwent 5 runs in each medium separately, and the means were calculated. The measured outcomes were maximum drained volume, flow rate, and the time to drain 200. Here's the graph showing the maximum drained volume. This is the non-clogging medium. There was no difference between them. But when we compared the 3 catheters in the clogging medium, there was a statistically significant difference in favor of the multi-pod catheter to both the closed tip control and the open tip control. Here's a graph showing the flow rate. The yellow line represents our catheter. The dark blue represents the open tip control, and the lighter blue represents the closed tip control. As you can see here, there was no difference in the non-clogging medium, but in the clogging medium, it showed a significant difference, as demonstrated. For example, our catheter drained 300 ml within 4 minutes, whereas the closed tip and the open tip drained 100 ml and 150 ml respectively. And this is a graph showing time to drain 200 ml. The open tip catheter couldn't reach 200. It stops around 95 ml, so we couldn't calculate it. We just calculated our catheter versus the closed tip catheter. The closed tip catheter drained 200 ml within 570 seconds, whereas our catheter drained the same volume within around 100 seconds, with a statistically significant difference. So our conclusion is that our newly designed multi-pod catheter offers better drainage compared to existing catheters in a clogging environment that simulates most body applications. Our future plan is further design iterations, dosing verification, animal model tests, and regulatory approval and validation, and then to exit and sell out to a major medical device company. هذه الصورة التي من اللطيف راحت وبس. Thank you everyone for listening. I'm happy to hear any question.
يعطيك العافية دكتور أحمد. دكاترة إذا في أي أسئلة لكم, we have 2 minutes. تفضل.
You, دكتور, ما شاء الله تبارك الله, nice concept. But my question is, why did you choose in the clogging material cotton and sodium polyacrylate?
تمام. سوينا كونسلتيشن لأحد الشركات اللي برا المختصة بالكيمياء. سألناهم قلنا لهم الفكرة حقت we told them our concept and we told them what kind of fluid we want to mimic. They advised us to use these materials. The sodium polyacrylates can mimic the pus with the same amount of viscosity, around the same amount of viscosity. Let alone that we are very aware that this is a dry lab study, so there are some limitations that cannot be overcome. We hope in the future testing with the animal trials, we can make sure what fluid exactly we can simulate.
Thank you.
Thank you.
I would like to say that we are very proud of you. I'm proud of all the students that are presenting today. Having this, coming with such patency and then applying research just to make sure that it's really working. It's really very, very something which makes us really proud. Can I see just the, if you can go back? Can you go back, or it's difficult? Yeah. Can you go back? Okay. I just want to, I want to see the results, the last one. Last. All
right, I'm going there. And all of this wouldn't happen without Prof. Ayman Al-Jazairi supervising.
MashaAllah. And let me congratulate you with your graphs and your flow chart. Very nice, very well presented, MashaAllah.
Thank you.
Back. Go, yes.
This one?
Okay, here, this one, yes. So, okay. I was looking for the p-value. Do you have an accurate p-value? Was it just highly significant or just significant?
It was around 0.0032 for the comparing the multi-port catheter to the cluster.
Okay, so it was highly significant.
Yeah, it was
highly significant. Okay, highly significant. And because I cannot see any numbers here or percentages, if you can put them, it would be good. And if you put your p-value, since it's highly significant, it's very important to be here. Okay.
Mm-hmm. Sure.
Yeah, and it gives more strength to your presenting to the results. Okay, thank you very much.
Thank you so much.
Okay, Ahmed, again, I would like to congratulate you for this innovative work, patency, and doing now experimental and trial, and hopefully it will pass through the all stage of clinical application and examination. I have a question and maybe point for clarification. My question: what is the limitation of this new catheter compared to others? You brought the strength of this catheter. What about its cost, for example? What about its material? What about the difficulties in insertion? Is there any clear difficulties and limitation of this catheter? This is my first question. And my second question: what is the role of you as a medical student in this project? What is the exact role? Are you the one who create the patent? Are you the one who did the analysis of the result, or what? I would like to know more, please.
Okay, absolutely. Regarding our role, it was the patent was submitted and collected by Prof. Ayman. We are, as medical student, we run the clinical trial themselves under the supervision with the doctor. As you can see here, this is exactly what we were doing. All of us are medical students. We are making sure that the environment is accurately set. We calculate the volume via the water seal, and using a timer we insert it to the computer directly. Regarding the first question, can you just recall me what it was?
Yeah, I said, what is the limitation of this catheter in compared to others?
Yes, sure. This is our first catheter. It's a prototype. We faced some problems. For example, the tip of the catheter dislodged from, during one of the experiments. So we had to replace that catheter. So we have to make sure this wouldn't happen again with further designing. For the design itself, we couldn't assess the design property using the dry lab only. We are aiming to proceed to animal trials, which would give us more perspective on how is our catheter working exactly. But we are well aware that we will face multiple challenges regarding the design, and we are willing to change it 3 to 4 times. This is in our plan.
شكرا يا أحمد، الله يعطيكم العافية.
الله يعطيك، شكرا. Thank you so much everyone.
العافية أحمد زيد يحيى على البرزنتيشن، وشكرا لك.
الله يخليك.
البرزنتيشن الجاي الدكتور عبد الله الضحيان. You can share your screen now. دكتور عبد الله you can start now.
بروف محمد معلش احنا بانتظار تقييمك.
يلا يا بنتي دقيقة الآن أبي سبمت.
السلام عليكم. أتمنى صوتكم واضح.
اي واضح دكتور، تفضل. سوي شير سكرين بس للبرزنتيشن.
أقدر أبدأ؟
بس سوي شير للسكرين، ما البرزنتيشن مو واضح قدامنا.
واضح لكم الآن؟
اي موجود، تفضل دكتور.
بسم الله. My name is Abdullah Dhayyan, medical intern at King Khalid University Hospital. I'm going to present our research today, a novel use of fully absorbable phase X mesh for laparoscopic inguinal hernia repair. First, in the introduction, the synthetic mesh has routinely been used for inguinal repair since its introduction. Polyethylene, Dacron, and polypropylene meshes were used in previous decades. The sequelae of the herniorrhaphy with the synthetic mesh may include chronic pain, mesh shrinkage, chronic inflammation, and mesh fixation are possible causes of chronic pain. So the degree of the chronic pain and shrinkage may the primary cause of the chronic pain. Using less foreign material will decrease chronic inflammation and its sequelae. Additionally, an inflammatory tissue reaction to mesh may occur for years, so resulting in scar formation, which may induce chronic pain. Inguinal hernia is usually repaired with the synthetic non-absorbable mesh, resulting in collagen formation, chronic inflammation, and fibrosis with significantly reduced hernia recurrence. However, chronic pain may affect the quality of life. So, poly-4-hydroxybutyrate mesh was introduced to minimize complication and to start degrade in 12 to 19 months. The study assessed the consequences and result of patients undergoing transabdominal periperitoneal inguinal hernia repair using P4HP mesh physics, our mesh used in this study. We performed a pilot study for laparoscopic TAB repair for inguinal hernia using P4HP mesh in 15 patients, 14 male and 1 female with an average age of 55.8 years old and an average body mass index of 27.4 kilogram per square meter. We assessed the recurrence rate and the patient chronic pain for 13 months. The study was conducted from January 2016 to July 2017 in Medical City of King Saud University. We measured post-operative pain, reactions, mesh sensation, discomfort, and recurrence for hernia. We recruited 15 patients who met our inclusion criteria. These were aged from 18 to 84 years old, diagnosed with primary inguinal hernia, medically fit for general anesthesia, and finally suitable for laparoscopic TAB procedure using 15 by 15 centimeter phasic mesh. Result in total, we encountered no recurrence or mesh sensation except in one patient who experienced mild chronic inguinal pain for 1 year without activity restriction. So we find in our discussion, the main finding of the study was that P4HB mesh is feasible and a viable alternative to current mesh products for use in inguinal hernia repairs and demonstrate safe and effective clinical outcomes. Indeed, inguinal hernias represent some of the most common surgical problems worldwide. Initially, the synthetic non-absorbable polymer products such as polypropylene were used because of their various advantageous physical properties, including their inherent tensile strength, flexibility, and ease of cutting with the surgical tools, consequently reducing hernia recurrence rates dramatically. However, some mesh products such as polypropylene as shrinkable, which could cause chronic pain and stiffness of the abdominal wall. The occurrence of the chronic pain increased substantially and became most frequent and desired side effect of hernia repair. So here we used physics for direct and indirect hernia without recurrence, and absorption commenced within 12 months, which is sufficient for deposition of maturation of collagen. Light of above, B4HB is a novel, fully absorbable, naturally occurring monofilament, which is fully absorbed in 12 to 18 months in the preclinical trial of Brocaine mode. B4HB exhibit desirable characteristic for hernia repair, including markedly increased robust stiffness, amplified suture retention, tear resistance, and ball burst strength. We hypothesize that this quality facilitates smooth and gradual transfer of load into natural abdominal tissues, reducing the risk of premature load transfer and recurrence. So we concluded that laparoscopic TAB inguinal repair using poly-4 hydroxybutyrate mesh is safe for combined direct and indirect inguinal hernia with no recurrence. B4HB absorbable mesh cause less chronic pain and discomfort. So we recommend longer follow-up, more patient, and 15 patients required using synthetic mesh are necessary to assess the utility of B4HB for inguinal hernia repair globally. That's it, and thank you. And also, I have to mention that we already published this study in Journal of Society Laparoscopic and Robotic Surgeons.
يعطيك العافية عبد الله على البرزنتيشن. دكاترة, we have 2 minutes. تفضلوا.
I just have a question regarding really the number of patients is only 15 patients. Did you try to find the right sample size for the study? Did you calculate it, or you included these 15 patients? That's it. Because I don't know if you have enough power to really suggest or recommend these results.
So this is, I think, from our consultant who did the procedure and used this mesh. As this pilot study, and one from our recommendation to increase the number.
So this is a pilot study. You didn't mention that. You want to say that this is a pilot study? Sorry, maybe I missed it. Okay. Okay.
Yes, I have three questions for you, Dr. Karim. First one is there a similar interventions or interventional studies using similar material than elsewhere, and did you compare your result with them? This is my first question. The second, did you pass through the stage of interventions? I mean, is this material tried first on animal maybe before? I don't know if this applied or not. And my last question, what is again your exact role as medical student in such a project, please? Thank you.
Okay, maybe some question we have to ask Prof. Our rules in this study: follow up patient and ask patient if there is a complication of the hernia repair, like seroma or foreign body sensation or pain or recurrence. That's our rule. I think they already did it in vitro for this study. Also, I think they also this type of mesh use in plastic surgery. But our role as medical student was in follow-up for patients, writing result, and that's it.
Okay. Can I ask you a question, please? I would like to ask you, if you had to do the study again, what kind of methodology would you use?
Maybe clinical trials.
Okay. So, okay, you are going to compare these two types of matrix, right? And you will see the outcome, whether the pain, the chronic pain has reduced or not. So, do you think this is the proper or right design to be to include? I'm saying this because this is pilot. Probably you might change and change the design for such study.
Yes.
Okay.
طيب يعطيكم العافية دكاترة، وشكرا دكتور عبد الله ضحيان على البرزنتيشن.
يعطيكم العافية، شكرا لكم.
أهلا وسهلا. Next up will be Dr. Hiba Rahil. Dr. Hiba, you can now share your screen.
Okay, hello.
Hello, Dr. Hiba.
Is my screen clear?
Yes, you can see.
Okay. So, Assalamu alaikum, respected judges and my fellow participants. My name is Hiba Rahil, and I'm a third-year medical student studying at Al Faisal University. First of all, thank you for giving me this opportunity to present on this conference, and I'm looking forward to receiving your feedback on my research. On behalf of my team, I'm going to be presenting our research on the topic establishment of a school health surveillance program, a healthy school initiative. So I will start by highlighting the importance of this topic. The WHO emphasizes that an efficient school health program can be one of the most cost-effective investments that a nation makes in order to improve the education and health of its citizens simultaneously. Studies that were previously conducted show that through regular monitoring and checkup of students, of school-going students, can lead to disease identification and prevention before it progresses into a serious illness. Our research question was that what is the prevalence of modifiable risk factors such as obesity, depression, diabetes, and smoking, as well as non-modifiable risk factors like hypertension, asthma, and tuberculosis among school adolescents. We had three main study objectives. Number one, to conduct a baseline survey to determine the prevalence of modifiable and non-modifiable risk factors previously mentioned in a non-native school in Riyadh among adolescents. Number two, we plan to establish an electronic medical record system in the school to monitor the health of the students. And finally, we plan to introduce certain programs as part of our interventions to target the found risk factors and to improve the healthy habits habits of the students. We hypothesize that our study participants will have a higher prevalence of depression, obesity, hypertension, diabetes, and smoking. Moving on to our methodology, we conducted a cross-sectional population-based study in a community-based school called the Pakistan International School, which enrolls about 3,000 Pakistani national kids from grades 1 to 12. Students who were included in our study were boys and girls from grades 8 to 12, and students should be enrolled in the school for at least 6 months, and they should be able to communicate in English. As for the parents and students who did not give us their informed consent, were not part of the study. Our study utilized 3 main tools. Number 1, the WHO Global School-Based Student Health Survey, which is a self-administered questionnaire that was filled by the students to identify their health habits and behaviors and certain risk factors that lead to the morbidity and mortality among these children. Number 2, we utilized the PHQA scale, which is a tool used to assess the prevalence of depression among adolescents in particular. And lastly, we designed a biometric assessment tool in order to measure the height, weight, blood pressure, and the visual acuity of the students. And using the height and weight, we measured the BMI. In addition, we also had a week of training for the school nurses and the science teachers, and they helped us in the biometric measurements and the assessment of the students. So our sample size was calculated using the OpenEpi version 3 calculator, and here are some snapshots present here of the calculator that was used. And it was found that 151 males and 139 females were to be involved in the study. And the PPS method was used to select the required sample size. Moving on to our results. This is a table showing the social demographic data of our respondents, and it was found that around 60% of the study respondents were living in Riyadh since birth, and around 60% of the study respondents had fathers who were unskilled workers, meaning that they were painters, drivers, or shopkeepers. And around 80% respondents had mothers who were housewives. Figure 1 shows the baseline assessment of and the habits of our participant, and it was found that around 38% of the students were overweight and obese, and around 18% of the students were prehypertensive and hypertensive. In this figure, differing rates of depression are demonstrated, and we calculated 27% of our study participants to have moderate to severe depression. In this graph, it is shown that around 32% of the study respondents consumed some form of tobacco, and these are the different types of tobacco used by them. The next step that our team did was that we converted all the data that was collected into an electronic medical record system for the school to monitor the health of the students. And perhaps the key indicators that this school health surveillance data sheet includes are the BMI status and the screening for high blood pressure. And we hope to utilize this data sheet to monitor the effectiveness of our interventions that we plan on including. Moving on to our discussion. So to the best of our knowledge, this is the first study conducted in a non-Saudi adolescent population in KSA, which shows such high rates of obesity, high blood pressure, and generally unhealthy habits. And second, our study showed that there were 27% of students who had depression, which is a much higher figure stated by the Jelena study, which was conducted on Saudi adolescents. And finally, our study participants were twice as more likely to be overweight and obese as compared to local Saudi population. The limitations of our study was that our findings, they cannot be generalized to all international schools and adolescents in KSA. To conclude the presentation, we conclude that there was a high prevalence of both modifiable and non-modifiable risk factors found in this population, and that an electronic surveillance database was established in order to monitor these risk factors and the health of the students over time. Certain programs were introduced into, or will be introduced into the population as part of the interventions in order to reduce the risk factors and to implement certain healthy habits among the students. We recommend the following recommendations to the school. Number one, tobacco cessation program in order to reduce the high rates of tobacco consumption. Number two, mindfulness cognitive-based therapy in order to reduce the high rates of found depression and to promote mental well-being among the students. And we encourage the school to also implement certain dental and general hygiene promotion awareness program to promote the health hygiene. And lastly, physical activity promotion program should also be introduced to reduce the high rates of sedentary lifestyle and to encourage the students to have a more active lifestyle. With that being said, these are our references, and thank you for your attention, and I'm ready to accept any questions that you may have.
Thank you, Dr. Hiba, for this good presentation. Doctors, if you have any questions, we have 2 minutes, please.
Yes, Dr. Hiba, mashallah, tabarakallah, well done, and how to project it. My question is about your recommendations. Is it that you just told the school, please do 1, 2, 3, 4, or you actually provided them with this material to do, for example, programs to stop smoking and physical activity and so on?
Right. So the first program that we helped the students, or we helped the school with, was the dental and general hygiene promotion awareness program, in which we conducted this intervention along with the student, with the help of the school, and we did it on the students. In fact, we have a poster on this that we're presenting tomorrow in the conference, and it was an entire program that we conducted, and it was over a period of a month. And we talked about general hygiene, hand hygiene, the importance of personal hygiene and dental hygiene. And we demonstrated the correct way to wash your hands, to brush your teeth. And we also monitored their practices and the change in practices over time.
Okay, mashallah, very well done, Dr. Hiba. I have a few questions, really. I wanted to ask, you said that the student filled the questionnaire. Did you have any problem in missing data or problems regarding that? This is the first question. The second question, you said that they had high blood pressure, and you measured their blood pressure, right? You measured it how many times? Once?
Okay, so the first
time. Did you use the appropriate sphygmomanometer for their weight, and you made sure that the obese you've done all that, because you did not mention it. Okay. Also, I thought that there is something missing, which is a very common problem in adolescent that you did not include. Maybe you can include later on, which is the iron deficiency anemia. I know it's you need to take blood, and maybe it causes a lot of problems, but this is also another important problem that we face in school children. And I believe that it's as important as the other aspects, so as it can be treated early and early on. Otherwise, thank you very much.
All right, can I please answer your questions?
Yeah, definitely.
Right. So as for the missing data, yes, there were a lot of discrepancies, and we had a lot of missing data and missing variables. In order to do that, we had to filter the data and modify our sample size. Like from the sample size that we used, we kept a margin of a certain number of data that maybe the forms were not filled right, or there was some problem. So this was already included as part of our sample size. And these obviously forms were not included as part of the main results that you saw. As for your blood pressure question, yes, we used the sphygmomanometer, and we trained all the personnel that were present at that time on how to measure the blood pressure correctly. And those students that had a high blood pressure, their names were written down and it was given to the school nurse. And the school nurse was asked to follow up with these students over a period of time. And then because we also thought that maybe because of the stress or white coat, there's something called white coat stress, maybe because of several factors, their blood pressure was raised at that time. And for that, they were followed through and several readings were taken. And if the blood pressure was high in consecutive 3 or 4 readings, then their parents were contacted and these students were referred to a clinic. And for your anemia, the anemia suggestion, that is very, very valuable suggestion. Thank you so much for that. We weren't sure if we were allowed to draw the blood of the students, and these are just 8th to 12th graders. So this was an ethical consideration that we had to keep in mind. However, it is a very good recommendation, and we can definitely implement it in the future. Thank you so much.
Thank you, Dr. Hiba. I really enjoy your presentation and the study, different part of the study, and you're already having multiple objectives in one project, and you can divide it easily into 2 or 3 projects. However, if you would like to publish this work, I may advise you to remove the area related to hypertension because it is really looks strange and it may create a lot of questions. The result is not comparable to the usual prevalence of hypertension among this age group, and people may bring big questions regarding the methodology and the accuracy of the diagnosis. I think you have enough data, maybe if you would like to publish regarding different risk factors, modifiable and non-modifiable risk factors, as well as the teaching and training programs you conducted. Thank you so much.
Thank you, Doctor. And that is very valuable input as well. We are in the process of publishing it. We're in the final phases of publication. And we are not diagnosing the students with a disease. We are just screening them. So we screen them for high blood pressure, and then they were followed up with, and then they were referred to a tertiary care hospital. So but thank you for your suggestion, and we'll keep it in mind.
Okay, Abdulaziz, Lulu, are we done?
Thank you, Doctor. We have one last. Lamis, are you here?
Yes, we have one last presentation. Dr. Lamis At-Tamimi. Thank you, Dr. Hiba. Dr. Lamis, you can share your screen now. Dr. Lamis.
دكتورة لميس الصوت ميوت معاكي.
السلام عليكم.
وعليكم السلام، اهلا وسهلا دكتورة. تقدرين تفضلين تسوين شير سكرين؟
ان شاء الله. السلام عليكم، صوت واضح؟ الو، السلام عليكم.
واضح، تفضل.
Hi everyone, this is Lamis Tamimi, a medical intern from King Saud University. It's my pleasure to present our research topic today, which is viral therapy, an emerging modality to overcome the mystery of triple negative breast cancer treatment resistance. Now, talking about breast cancer, we all know that breast cancer is quite prevalent, especially among female patients. One of the most recent studies, which was published in 2020, reported a prevalence of up to 28%. So that's almost the third of cancer population of having breast cancer. Now, talking about breast cancer, we have multiple types in breast cancer. We have estrogen positive, progesterone positive, and HER2 positive. And we have one fourth type, which is triple negative breast cancer, which is defined of being negative for progesterone, negative for estrogen, and negative for HER2. Now, let's look closely to the statistics of breast cancer population. Triple negative breast cancer was reported to be up to 15% out of all breast cancer population. So that's quite prevalent. That's a huge percentage. Now, what makes triple negative breast cancer more complicated that it does present in young patients, younger than 40 years of age. We usually have breast cancer patients presenting more than 50 years of age. And you might ask, what is the current, now we usually treat breast cancer by targeting the expressions, like targeting hormonal therapy, which targets the expressed receptors, which is estrogen and progesterone. And we have biological therapy, which is targeting HER2 receptors. Now, what we are going to do with the triple negative breast cancer, the mainstay is chemotherapy, but it's not that effective. And what makes triple negative breast cancer more mysterious is different people or different patients diagnosed with that type of cancer responds differently differently to chemotherapy. That means we don't know a lot about breast cancer, and we don't have an effective treatment. Treatment for triple negative breast cancer. Now, a lot of time has been spent, a lot of money was spent in clinical trials, testing all of those biological agents, chemotherapy receptors, immunotherapy. A lot of studies was trying to achieve personalized treatment for triple negative breast cancer, and that's a lot of cost. Now, we have heard, we are, as a group of researchers, interested in oncology in general, and specifically in triple negative breast cancer. We have heard that, we have heard about a news in 2015, which was published in 2015, from that the FDA, the US FDA, approved the first biologically designed viral therapy targeting the treatment of advanced melanoma in the United States. And we have seen some publications, searched the literature, and found some publication testing this viral therapy in different types of cancer, like melanoma, gliomas, and pancreatic cancer. So that raised the question, and this is the rationale of this study, that raised the question for us as a group of researchers to examine and to investigate the efficacy of viruses in the treatment of triple negative breast cancer, because it's a new emerging modality. So we designed our study, which was a systematic review. We reviewed PubMed, Medline, Google Scholar, Cochrane, and other search engines for the past 10 years. Using our keywords, it was an extensive review article, which found only 6 studies, initially 10 studies were found, talking generally about the viral therapy. 6 studies were found relevant, and no single study was published regarding the topic. I mean, systematic review study that cumulate all efforts. So let me give you a little of background information of what we found. We found that let me talk a little bit of the viral therapy. So what is the idea of it? These are biologically engineered, live attenuated or attenuated viral therapies. Herpes virus was used, measles virus, adenoviruses and retroviruses were used and biologically engineered and examined under clinical trials. Those viruses will come to the cells, infect them, achieve infectivity, then cytotoxic effects inside those cell lines. We found that the activation of mitogen-activated protein kinase pathway is highly suspected to be the cause of resistance to conventional chemotherapy, biological agents, and the responsible pathway for poor clinical outcomes. So we are presenting our results. This study was one of the leading studies that we have found in talking about the viral therapy. Here are the cell lines, 1, 2, 3, 4, 5 cell lines, and these are the days. Horizontally, we are presenting the days. So, and those are green dots are the viruses. So we have plates. Those studies had plates. Then the viruses were stained with green fluorescent. Then thrown inside the cells. So day 1, till day 3, and there are other days. You can see like the viruses are infecting and increasing in number in each cell line, showed great infectivity, and that infectivity was dose dependent. And we have, as you see here, highly susceptible cell lines, and we have less sensitive cell lines. The result was in highly sensitive cell lines, up to 90% cell killing was achieved by the 7th day, and in less sensitive cell lines, up to 70% cell killing was achieved in the 7th day. So that tells us that the viral therapy could be of high efficacy in treating triple-negative breast cancer. We have made a summary of all the articles that we have found, most important articles, examining retroviruses. Those are the pathways. This is the most effective or most highly suspected pathway. And as you can see here, all of those are very recent articles, no one publication before 10 years. Now, these are the highlights of our systematic review, that the viral therapy has been studied also in combination with chemotherapy and achieved oncolytic efficacy. And it was effective even with combination with cyclophosphamide and one of the most famous chemotherapy, which is cisplatin. Also, studies provided evidence of temozolamide's ability to increase the oncolytic effect of virotherapy. So we report here effect of synergism of viral therapy. So it's not only effective, it can achieve synergism. Also, they have demonstrated its ability to increase apoptosis in vitro and induction of cell death. Lastly, the last one was the vaccinavirus, which is after treatment, all harvested lymph nodes and organs showed no evidence of metastatic cells. All harvested tumors showed complete response to treatment with only necrosis and fibrosis. So we can conclude that the viral therapy could be a promising modality in treatment of triple-negative breast cancer. Our research efforts, money, and funds could be directed toward investigating more in the viral therapy, because we have only found few studies investigating investigating it and suspecting it, despite that the idea was innovated in 2011. The first study was published in 2011. So till now, we don't have sufficient research in the field of viral therapy as we have in the field of immunotherapy and chemotherapy. Chemotherapy could be effective in other types of cancers, but it's not the case in triple-negative breast cancer. And as also our study shows that it could be a combination therapy with chemotherapy, immunotherapy, neoadjuvant therapy. So why don't we invest in research in viral therapy in treatment of triple-negative breast cancer? Thank you.
يعطيك العافية دكتورة لميس على البرزنتيشن. دكاترة 2 minutes for discussion. You can start now. تفضل.
Dr. Lamis, I really enjoyed your presentation, and you seem to very motivated and eager to this the viral therapy. My question is really, were there any mention of the side effects of this viral therapy on patients who are already having breast cancer? I mean, okay, we are looking at it as a treatment, but were there side effects or problems given this treatment?
Mm-hmm. Well, doctor, all the studies that we have found only in vitro phase. There were no single study in that clinical phase. So all,
what about animals? Animals, I'm talking about animals.
Yeah, in animals, in the studies that we have found, they didn't report any side effects and any cytotoxic effects. Okay. Only cytolysis effect in the killing of the cancer, as per the articles. Mm-hmm.
Okay.
Again, I'd like to congratulate you for this presentation, and you look also enthusiastic to give a new modality of treatment for this important health condition. My question here, is this considered as a review article? Are you did you apply all the concepts of review literatures and analysis and critical analysis of the published work? My second question is, again, what is your role as medical student in this particular project? Thank you.
Okay, well, regarding the first question of which was sorry, I forgot the question.
I said, is this you consider it as an review
article? Okay, thank you.
And
so
you the concepts of review articles here? Yes.
Yes, sure. All the review article concepts were applied. We have extensively searched all the engines, and we have specified our keywords, and then the elimination criteria for all studies that were not relevant. Then we have examined the quality of all the studies that are involved, and examined their methodology, have read it and referred it to the consultants to examine it again. When all the studies were approved, we moved into extracting the data out of them, putting them into schedules. And the thing regarding analysis of the results, we have thought about this idea, but unfortunately, this idea was not applicable in our case, because each and every clinical trial article was published was talking about different pathway and different virus, which made combining them in one analysis was not applicable. We wish that we had some analysis that would make the article more stronger, but unfortunately we couldn't combine it because they were talking about different viruses.
Yeah, usually whenever you will be able to merge all of these results together, then you will convert it into meta-analysis. But now you are applying an overview or a review article model or of research. I think it's worth in the future, and if you want to publish, to cite it clearly in your presentation and to compare between different articles, the way searching for your included articles and the way you validate them. That will be important, especially for publication. My second question, I think your role is...
we have conducted all the study from the beginning till the end. The doctors were only supervising. We are 2 medical students. I'm a medical intern now. We have conducted the study from the beginning till the end, collecting the data and even writing and everything.
Yeah, it's clear. You are confident with the article and how you analyze the result. Thank you, Dr. Alamis. Allah يوفقك.
Thank you.
بالتوفيق يا دكتورة.
شكرا جزيلا. Thank you for your valuable feedback.
شكرا لك دكتورة لميس، يعطيك العافية. وبكذا دكاترة we finish our presentation for today. Thank you دكتورة بروف الجوهر القويز، بروف محمد الركبان، ودكتورة خلود الزين على for joining us and evaluating the presentations. We'll continue.
Thank you very much.
Thank you, Dr. We'll continue tomorrow, inshallah, at 11 for our oral presentations. We'll be preceded by poster presentations, so you can join us tomorrow. For now, we'll end this presentation, but we will continue through poster presentation. 4 links will be shared on our social media. You're more than welcome to join us. Thank you for everyone.
يعطيكم العافية يا دكاترة، شاكرين لكم الوقت اللي أعطيتونا والجهد اللي بذلتوه معنا، وشاكرين الحضور.
الله يخليكم، احنا اللي والله اشكركم صراحة على هذا التنظيم الرائع والتنسيق والضبط وايضا كواليتي اوف البروجكت اللي قدمت، حقيقة شيء يدعو للفخر. شكرا لكم، احنا الحقيقة سعيدين بهذه المشاركة.
الله يسعدك.
جدا جدا سعيدين.
يعطيكم العافية جميعا دكتور خلود، بروف ركبان، بروف الجوهرة. I'm very pleased to I'm happy to see your very valuable input to our students as well. So I hope you have a good rest of the weekend. Inshallah we'll see the results and probably early next week بإذن الله who would make it to the top. يعطيكم العافية جميعا. Thank you so much.
مع السلامة.